There's this classic scene in almost every medical drama. The one the patient walks in, lists a few vague symptoms, and the brilliant doctor just stares off into the distance for a second, tilts their head, and then boom, obscure diagnosis. It looks like magic.
It really does. But it's actually closer to an algorithm. It's a decision tree. And, the reality is often more impressive than the TV version because it relies on these really subtle clues that most of us just completely ignore.
That is exactly what we are digging into today. We have a stack of training materials here, specifically on ENT history taking for nose cases. This is basically the playbook that an ear, nose, and throat specialist uses to interrogate a patient.
Right, interview. And it's a fascinating document because it flips the script on how we think about a doctor's visit. We assume the diagnosis happens when they stick that camera up your nose or look at a CT scan. But this guide argues that the history, just the conversation, is where maybe 80% of the diagnosis is made.
80%? That is a huge number. I mean, if my mechanic told me what was wrong with my car just by me describing the weird noise it's making, I'd be amazed.
It's the Pareto principle of medicine, really. The physical exam usually just confirms what the doctor already suspects based on the story you've told them. If they ask the right questions, the patient practically hands them the diagnosis.
So our mission today is to reverse engineer those questions. We're going to look at the 4 pillars of a nasal complaint: blockage, discharge, bleeding, and pain and just. Figure out the logic behind them. Why does an ENT care if my nose gets stuffy in the morning versus the afternoon? Or the specific texture of my snot?
It sounds gross, but that texture is basically a biological code. We'll get there.
Okay, let's start with that first pillar, the chief complaint of nasal obstruction, the blocked nose. Now, to me, a blocked nose is a blocked nose. I can't breathe, end of story. But the source material, right away, makes this distinction between a physical obstruction and the sensation of obstruction.
Yeah, and this is a really crucial concept. We all assume that if we feel blocked, something is physically plugged up in there. But the nose is lined with these incredibly sensitive nerve endings. You can have a totally open airway, physically clear, but if those nerves aren't detecting the airflow right, your brain starts screaming suffocation.
Wow. So you're breathing, your brain thinks you aren't. That sounds awful.
It's often called paradoxical obstruction. It's basically a sensor error. The hardware is fine, but the software is glitching, which is why the doctor has to dig deeper than just, I can't breathe. But let's assume it is a physical block. The real detective work starts with the timeline. The guide is super specific about asking, is this block constant or does it come and go?
And the time of day, morning versus afternoon. I always assume this was just small talk, but there's a real physiological reason for asking, right?
A huge reason. If you tell me I wake up completely blocked, but by 11 a.m. I'm fine, my mind immediately goes to your bedroom environment. That is a classic signature of allergic rhinitis, probably triggered by dust mites in your pillow or pet dander. You spend 8 hours marinating in it, you wake up inflamed, and then you leave the room and it gets better.
Okay, so morning block could be a bedroom allergy.
Yeah.
What about the reverse? I wake up fine, but by 4 p.m., I can't breathe.
Then I'm looking at your workplace, or maybe pollution levels. But it could also be something called vasomotor rhinitis. This is where the blood vessels in the nose are just hyper-reactive. They react to changes in temperature, humidity, even stress. It's not an allergy, it's a blood flow thing.
Now, here's the part of the notes that really blew my mind, the nasal cycle. The source mentions asking if the blockage switches sides, and apparently if the patient says, yeah, sometimes it's my left nostril, sometimes it's the right, the doctor's actually relieved.
Yes. It's one of those little facts that ENTs love. Most people don't realize this, but we rarely breathe through both nostrils evenly at the same time. We have a physiological cycle, maybe every 4 to 6 hours, where the inferior turbinate, that's the erectile tissue inside the nose, swells up on one side and shrinks on the other.
Wait, hold on, erectile tissue? In the nose?
Structurally, yes. It's highly vascular tissue that engorges with blood, very similar to other areas of the body. So one side rests and humidifies while the other does a heavy lifting of airflow. Then they switch. It's how the nose recharges its moisture.
That is wild. My nose is taking shifts.
Precisely. So if a patient describes an alternating blockage, it tells the doctor that the basic physiology is working. The mechanism is intact. It's just maybe reacting too strongly to something, like a cold or an allergy. The cycle is still happening. It's just amplified.
So alternating is good, or at least it's manageable. What's the bad version?
The bad version is fixed, progressive, unilateral.
Okay, let's break that down because those sound like serious words.
Unilateral means it's always the same side. The left nostril is blocked, the right is fine. It never, ever swaps. Progressive means it's been getting steadily worse over months. It started as a little annoyance, now it's a total wall.
And fixed means it never clears up. Not in the shower, not with the spray, nothing.
Correct. And if you have those 3 traits, fixed, progressive, unilateral, that's when the alarm bells go off. We're not dealing with a cycle anymore, we're dealing with something structural that's occupying that space. It could be a really bad deviated septum or a polyp, but in the back of the doctor's mind, they also have to rule out a tumor.
And that's why that simple question, does it switch sides, is so critical.
It's a fundamental fork in the road. One way is inflammation, the other is a potential mass.
And that leads into the other big timing distinction you mentioned, acute versus chronic. I feel like we use those words so casually. I have chronic back pain just means it hurts a lot. But in medicine, there's a hard cutoff, isn't there?
There is. In the world of the nose, the magic number is usually 12 weeks. If you've had symptoms for less than 4 weeks, it's acute. Probably viral, maybe a secondary bacterial infection. It's a skirmish. Your body's fighting a battle, and it'll probably win.
And if it's been going on longer than 12 weeks?
After 12 weeks, if the symptoms are still there, we call it chronic rhinosinusitis. At that point, the biology actually changes. It's not a simple infection anymore. It's a permanent change in the lining of the sinus. You can't just throw a 5-day course of antibiotics at a chronic problem. You have to treat it more like diabetes or high blood pressure. It's about long-term management.
That's a key insight for the patient too. If you've been stuffy for 4 months, you're not looking for a magic pill.
Exactly. You have to reset expectations. Now, speaking of things that show a battle is going on, we have to talk about the fluids.
The discharge. The source material calls this the visceral evidence.
It really is. It's the body's way of fleshing out the crime scene. And the training guide is very specific. You don't just ask, is your nose running? You have to ask, what does it look like?
Okay, so we've got 3 main categories here: watery, purulent, and mucopurulent. Let's start with watery. Seems pretty obvious.
Clear, thin, drips like a faucet. If you see this, you're usually thinking one of 2 things, most commonly. Allergic rhinitis. It's that sneezing, itching, watery triad. The body is literally trying to wash the pollen or dust out. It's a hydraulic defense.
A fire hose response.
Right, but, and here's a real deep dive detail that might freak you out a little bit. If a patient has clear, watery discharge from just one side, and it happens specifically when they lean forward.
Oh, I read this part. This is the scary one.
It could be a CSF leak, cerebrospinal fluid, the fluid that cushions your brain.
Wait, brain fluid is leaking out of their nose?
Sometimes, after a head trauma, or even spontaneously, a tiny hole can open in the bone between the brain and the nasal cavity, and the brain fluid leaks out. To an untrained eye, it looks exactly like a runny nose from an allergy. But if you miss that diagnosis, the patient can get meningitis.
That's terrifying. So watery is usually just allergies, but in rare cases, it's a whole breach in the skull. The stakes are high.
Medicine is all about ruling out the dangerous stuff. It's why that unilateral question keeps coming up. Allergies affect both sides. A CSF leak is usually just one.
Okay, let's move to purulent. This is the yellow or green thick stuff. We've always been told green means infection. Is that true, or is it an old wives' tale?
For the most part, yeah, it's true. The green color actually comes from an enzyme called myeloperoxidase. It's found inside neutrophils, which are the white blood cells that act as the infantry of your immune system. When they die fighting bacteria, they release this green enzyme.
So when you see green discharge, you are literally looking at the casualties of a microscopic war.
That's a vivid way to put it, but yes. Millions of dead white blood cells. So purulent means bacteria usually. It signals an active bacterial process.
And then there's the hybrid, mucopurulent.
Which is exactly what it sounds like, a mix. This is the most common presentation in chronic cases. It's thick, maybe pale yellow, sticky. It tells the doctor that the mucociliary clearance system is broken.
The muco what now?
Mucociliary clearance. Picture a microscopic conveyor belt of tiny hairs, cilia lining your nose. Their job is to constantly push mucus to the back of the throat to be swallowed. In chronic conditions, that conveyor belt just stops working. The mucus stagnates, gets sticky, gets a little infected. It's not a full-blown war zone like the green stuff, but it's a swamp.
It's amazing that the consistency of tissue can tell you so much.
It's a distinct language. You just have to be willing to look.
All right, let's move to the third pillar, the one that gets people to the doctor the fastest because it's visually terrifying. Bleeding. Epistaxis.
Epistaxis. Yeah, it's incredible how much panic seeing blood causes. But you have to remember, the nose is just packed with blood vessels. It's designed to warm the air, so it has this massive blood supply right near the surface.
And the source material says it's not enough to just say, I had a nosebleed.
No, context is everything. If you say, I blew my nose in February and there was a spot of blood, I'm not worried. That's likely Little's area.
Little's area. Is that a real medical term?
It is. It's a specific spot at the very front of the nasal septum where 5 different arteries meet up. It's like a high-traffic intersection for blood. It dries out easily, cracks, and bleeds. Annoying, but minor. We call it anterior bleeding.
But the guide contrasts that with profuse.
Profuse is the key word. We're talking about a flow you can't stop with simple pressure. Or, and this is critical bleeding that runs down the back of your throat instead of out the front.
Why does the direction matter so much?
Because if it's running down your throat, it's a posterior bleed. It's coming from way in the back of the nose, usually from a much larger artery. These are dangerous. You can lose a lot of blood very quickly, and you can't pinch it shut because the bleed is deep inside your head.
So a posterior bleed is like a pipe bursting in the basement instead of a leaky faucet in the kitchen.
That's a great analogy, and it's often linked to things like high blood pressure, which is why the history also has to cover medications. The guide explicitly mentions asking about blood thinners.
Right, like aspirin.
Exactly. But interestingly, the guide also points to nasal sprays as a cause.
The very thing people use to fix their nose.
Specifically, steroid sprays for allergies. It's often user error. If you aim the nozzle toward the middle of your nose at the septum day after day, you can thin out the lining until it bleeds. So the detective asks, show me how you use the spray. If they point it inward, that's the culprit.
So the fix isn't some big procedure. It's just teaching them to aim for their ear, not the center.
Aim for the ear to save the nose.
Right.
Exactly.
Okay, let's move to the final pillar, pain. The source calls this pain assessment, but I really like this idea of facial geography, the idea that X marks the spot.
The face is a map. The sinuses are air-filled cavities in the skull, and when they get blocked or infected, they put pressure on very specific places.
So let's run through the coordinates from the source. First up, pain on the bridge of the nose, right near the inner corner of your eye.
A lot of people assume this is sinus pain, but the source points to dacryocystitis.
I struggle to pronounce that one. That's the tear duct, isn't it?
It is. The lacrimal sac sits right there. If that gets infected, it swells up and hurts right on the side of the bridge. It has nothing to do with the sinus cavity itself, but it feels like it does.
Okay, what about deep pain between the eyes?
That is the ethmoid region. The ethmoid sinuses are like a honeycomb of tiny air cells right there. Infection causes a deep, dull, aching pressure that feels like it's behind your nose. Very distinct from a forehead headache.
And then there's the classic cheek pain, the one that feels like your whole face is heavy.
The maxillary sinus, the big one under your cheeks. But here's the really interesting part about the maxillary sinus. The floor of that sinus is often the roof of your upper teeth. The roots of your molars can actually push right up against the sinus floor.
So a sinus infection can feel like a toothache.
Oh, absolutely. And vice versa. A bad tooth infection can spread up into the sinus. Patients will go to the dentist complaining of tooth pain. The dentist finds nothing and sends them to us. It's referred pain from the pressure pushing down on the dental nerves.
That explains why the guide asks about the nature of the pain. Dull versus sharp.
Dull and bursting is usually pressure from congestion. Sharp and stabbing might suggest a nerve is involved, or an acute inflammatory spike. By triangulating the location and the type of pain, the doctor can often tell you which specific sinus is blocked without even looking at an x-ray.
It's really about narrowing the suspect list with every question.
That's all it is. You start with 50 possibilities, and with every answer, where does it hurt, what color is the fluid, what time does it happen, you eliminate 10.
We've covered the 4 pillars, but the source wraps up with this idea of broader context. Why is the social history, or past history, so vital?
Because the nose is the interface with the world. It filters everything you breathe. The guide emphasizes asking about your job. Are you a carpenter inhaling wood dust? A baker inhaling flour? These are major irritants. Wood dust in particular is actually a known carcinogen for the sinuses.
That's good to know. But what about previous surgeries? The source mentions asking about old operations. I feel like people often forget that. Oh, I broke my nose in high school, but that was 20 years ago.
They think it's irrelevant, but to a surgeon it's critical. Scar tissue is forever. If you've had a previous surgery, the anatomy inside is altered. The landmarks are gone. If the doctor goes in blind thinking it's a virgin nose, meaning untouched, they can get into real trouble.
Virgin nose? I didn't know that was a term.
It is. It means predictable anatomy. Once it's been operated on, all bets are off.
There was one note of the text I found kind of humanizing. It mentioned that a thorough history is key for passing Viva examinations.
Oh, the oral boards. Yes. The terror of every medical student. You stand in front of a panel of senior doctors and they just grill you on a case.
And the text suggests taking a good history is basically a shield against looking foolish.
It is. If you just guess the diagnosis, you'll get torn apart. But if you can present the case logically, this is a 45-year-old with unilateral progressive obstruction, mucopurulent discharge, and ethmoid pain, you sound like you get it. You're speaking the language.
And that confidence has to transfer to the patient too.
100%. If I ask you, you also get a headache between your eyes around 2 p.m. and you do? Suddenly, I'm not just a doctor, I'm a wizard. You trust me because I predicted your symptom, and that trust is what makes people actually follow the treatment plan.
It connects all the dots. It makes the patient feel seen, not just examined.
It turns a list of complaints into a coherent story, and that's where the healing actually starts.
So let's just recap this journey. We went from a vague, my nose is stuffy, to a highly structured investigation. We looked at the nasal cycle, the biochemistry of snot.
Green means dead neutrophils.
We've mapped the vascular highways of nosebleeds and the referred pain of the sinuses.
And hopefully we've shown that the nose isn't just a simple tube on your face, it's a complex dynamic organ. It's the gatekeeper for your entire respiratory system.
It filters, it warms, it protects, and occasionally it rebels.
It does, but it usually warns you first.
That's the key takeaway for me. The body is always broadcasting. We just need to learn the frequency.
Well said.
I want to leave you with a thought to chew on today. We talked about how pain on the bridge of the nose could be a tear duct issue, while pain in the cheek might actually be your teeth. It's a reminder of how interconnected everything is. So here's the question. What other specific localized signal is your body sending you right now? A little twitch, a specific ache, a recurring fatigue that you're writing off as just getting old, or stress, when it might actually be a precise coordinate pointing to a solvable problem?
That's a question worth asking.
Thanks for diving deep with us. We'll see you next time.